good afternoon, everybody, and welcome to Level 1 Trauma-Informed Care Training. I've been working on the Level 2 training, so I'm going to try and not mix things up here today. This training was developed in response to the organizational self-assessment that we've been doing over the last month here at Covenant House. Part of the findings from that assessment was that folks really were looking for some more unified training here at Covenant House on trauma-informed care. Particularly training that could help folks at the onboarding part of coming on here at Covenant House, and then some more advanced training related to like what do you do with the basic information you're going to get in this training. So before we get started, I just want to acknowledge that many of you, maybe perhaps a show of hands, how many of you have already had trauma-informed care training of some sort before? Okay, so most folks here probably are going to have some familiarity with the stuff that I'm talking about today. The Level 2 training is going to be the training that might be newer information for many of you in the room. However, what I'm really looking for today, especially from those of you who have a background in trauma-informed care, is some feedback on the training that I give today. The intention of this training is that everybody who gets hired on here at Covenant House will get this training before they even get started on the floor here at Covenant House. So if you can kind of try to put on your newcomer hat here and think about if you didn't really know anything about trauma-informed care, or you didn't know much about this sort of setting and the application in this setting, how would this training work for you? Would it be helpful? What's missing, etc. So I'd like to get that feedback from you so that I can integrate it into a revised version of the training if needed. I'll hand one to you. Everybody has this in front of them. The front page of this is actually a sort of in vivo evaluation of the training. So if you wouldn't mind throughout the training jotting down some of your thoughts in relation to the prompts on here, and then turning this in at the end of the training, that would be great. I'm utilizing these to get that feedback from you. If you want to keep this, you can keep it. I can snap a picture of it, or vice versa. You can snap a picture and hand me the hard copy. All right? That makes sense? Okay, there's some other worksheets in there too that we'll get to as we go. The last thing before we get going is just I like to put it on the table before I do any kind of training on trauma, that when we're talking about trauma, we are not talking about an issue of us and them. We're talking about a human issue. So this is my acknowledgement that there are very likely people in the room here today who have their own histories of adversity. And some of the things that I talk about or share about today could potentially be triggering or bothersome to you. So I invite you as we're going through this stuff to take care of yourself. Recognize if something is bothering you. Anybody in this room is welcome to get up, take a break, walk out. Nobody has to be here. You might for your employment purposes, but for my purposes, I would not be insulted if anybody needed to take a break or to stand up and walk around. Also, if you do decide to stand up and walk out of the room because you have to use the restroom, please know that I'll be thinking something is bothering you as well, okay? So this is a free-flowing environment. You can get up and come and go as you need to. Also, the last slide has my name on it and my contact information, so if anybody would like to follow up with me after the training for any reason, I'm available for that, and I can provide resources to folks or just sort of talk through some of the stuff that came up today if that would be helpful to you. All right? Okay. So let's see. I'd like to start the training by framing it with the principles of trauma-informed care, the 8 principles of trauma-informed care that have been set forth by a national homeless organization. This first principle is that a trauma-informed organization has an environment where every single person that works or utilizes the services in that setting or works in the setting, from an administrator to a floor staff to folks who are volunteers. Everybody in the organization has a basic understanding of what trauma is, how it impacts people, and why we're doing trauma-informed care. So this principle right here is the principle that this entire training is organized around today. But there's 7 other principles that I want us to keep in mind, which you should hear interwoven throughout the training today. But in addition to hearing it woven throughout the training, it's really important to understand these other principles so that you understand the comprehensiveness of what trauma-informed care is. So it goes far above and beyond you all just knowing what trauma is and how it impacts people. So trauma-informed environments are environments that promote safety for the people that utilize the services, or for the employees that are employed in that organization. It promotes safety by the way the physical structure is organized, how it's built. It promotes safety in the sense of how people treat one another, etc. So we'll talk a lot about safety today as part of an element of trauma and the understanding and impact of trauma. So therefore, the organization promotes safety. Trauma-informed organizations are organizations that recognize and ensure cultural competence among their employees. And I like to remind folks of this idea of cultural competence, again, is not an issue of an us and them, understanding other people's cultures who are different from you. That's an important part of cultural competence, is to understand other people. But from my perspective, one of the most important parts of cultural competence is understanding yourself and who you are and what you're bringing to the table that is then interacting with the folks that you're interacting with. So self-reflection on who you are and where you come from, in addition to learning about other people, is part of having a culturally competent organization. Trauma-informed organizations support consumer control, choice, and autonomy. In addition, there's shared power and governance in these organizations. So an element of trauma is that folks have their power taken away from them in the context of trauma. Therefore, organizations that inadvertently take power and control away from the people who utilize the services can be re-traumatizing to people. So in trauma-informed systems, there's an intention around developing policies and procedures and ways of relating with the people that we serve so that they have voice, they have choice, they feel like they can influence their environment as an element of healing. Likewise, staff has voice and choice and has some autonomy in the environment as well. Integrating care is an element of trauma-informed care. Here at Covenant House, we have South Central Foundation on site, providing medical services, behavioral health services. We have ASD that comes onto site, providing educational services. These are all elements of integrating care into one setting so that folks are able to access services and resources right here on site without having to run around the community and figure out where to go, et cetera. The 7th principle of trauma-informed care is one of the most important to today's training, and that is that healing happens in relationships. Each and every one of you, in every interaction that you have in your work here, whether it's with youth or with one another, you are introduced to opportunities that can be healing or not healing, just by the way that you position yourself in those relationships. So we'll talk more about this today, this important element. And finally, recovery from trauma is possible. You're going to hear me today talk about a lot of bothersome data about how trauma impacts people across the lifespan. And I might even forget to say this again, so I'm going to say it now so I don't forget. Recovery can happen. brains can change. So nothing that I'm telling you today is permanent. We have an opportunity to intervene, to shape our organizations, to work with people in every interaction to change their trajectory forward, okay? So that's what we're in the business of doing here. That's really the whole reason for trauma-informed care, is because we believe that recovery from trauma is not only possible, but people have a right to recover. All right? Okay. So back to the objectives, the specific objectives for this training. If I do my job well by the end of today, you all should be able to articulate a basic understanding of trauma. You should be able to articulate a basic understanding of how trauma manifests behaviorally. And you should be able to explain why trauma-informed care is a thing, why it matters, based on those two other bullet points. And hopefully, I'm going to give you a lot of technical language today. Please kick back and enjoy it. There's no test at the end. You don't need to remember the specifics of what I'm telling you. There's some basics. I want you to remember some of the basic information today, the general thrust of what I'm sharing. And I'll continue to bring back to that point and remind you, this is the take-home message. You don't need to remember all of the technicalities, okay? So these objectives here, you should be able to accomplish like over a dinner conversation with a friend, right? So you don't need to be able to go into all the technicalities, but you should be able to say like, yeah, trauma's a thing. It impacts people in this way, and we do trauma-informed care for this reason. All right? Shall we? Okay. So we are going to begin with the epidemiological justification of trauma-informed care. We'll start by defining what that means. So epidemiology is the study of population health, so health at the broadest level. And epidemiologists are interested in identifying factors that divisively lead to human problems, disease, etc. Therefore, with big data, if we can understand the things that are the biggest factors causing human problems, we can then develop interventions that can impact the greatest number of people and improve human health, right? Okay, so now a story. Back in the 1980s, there was a group of physicians working at Kaiser Permanente's Department of Preventive Medicine in San Diego, California. And they were running a weight management program in their clinic. And they noticed something peculiar in their program. They noticed that the folks who were the most successful in the program, that is the people who were losing the most weight the quickest, were also the people who were most likely to drop out of the program and for lack of better words, relapse into their ways that were maintaining their health problem. So they thought, this is an issue that we want to understand. They were researchers. So they conducted a study to try and understand what was happening with this group of people, that if they were experiencing success, why would they leave the program? And folks who weren't experiencing such success were sticking around, so they wanted to understand that. And what they found through this study was that this group of people seemed to be overeating and maintaining their weight almost as a function of protecting themselves from something. And when they looked at all of the different factors that might be at play, what they found was that they seemed to be maintaining this behavior in a way to protect themselves from something that happened to them way back in their childhood. And they weren't able, the patients themselves weren't able to say, I'm doing this because of this. But they were able to look at that through their data. So essentially what they came down to is that it seemed like obesity for this particular group of people was actually protective, that it protected people from attention from other people and kept people at a safe distance from them in particular ways. So this led to a really big study, the first epidemiological study of adverse childhood experiences and the impacts of these experiences on adult health. So they took a look at 17,000 people who were enrolled in a health insurance program in Southern California. And they took a look at these three broad forms of adverse experiences that these folks may have experienced before the age of 18. So abuse, neglect, and household challenges, and each of these breaks down into a few categories. The abuse category included emotional, physical, or sexual abuse. Neglect included emotional or physical neglect. And household challenges included exposure to domestic violence, exposure to substance abuse in the home, mental illness in the home, experiencing a parental separation or divorce, or having a parent incarcerated, all this before age 18. So they took a look at these data and then correlated it with all sorts of different health outcomes among these 17,000 people. And what they found is considered one of the most important epidemiological findings of our lifetime. And I'm going to share some of those data with you here. First of all, of these 17,000 people, they found that 67% had experienced at least one of those forms of adversities before the age of 18. And of those, 1/8 of the population had 4 or more of those adverse experiences prior to the age of 18. And importantly, 4 or more ACEs were predictive of some pretty significant health problems that I will read off to you because I recognize that is a teeny tiny little square down there. They found that 4 people who experienced 4 or more ACEs compared to those who had 0, so this is 4 compared to 0, had 3 times the level of lung disease and adult smoking. They had 11 times the level of intravenous drug use, 14 times the number of suicide attempts. They were 4 times more likely to have become sexually active before the age of 15. They were 4.5 times more likely to be depressed, and they had 2 times the level of liver disease. In addition to that, ACEs were strong predictors of obesity, chronic obstructive pulmonary disease, cardiovascular disease, and early death. So pretty powerful findings. As an epidemiologist, I'm not an epidemiologist, but epidemiologists will say that you don't find things like this very often. If you're able to identify something that so powerfully predicts what I just read off to you, those are the biggest killers of Americans today, right? If we're able to pinpoint and target that information, that is ammunition to be able to intervene and greatly improve human health, except it's a really hard thing to intervene with, right? So we'll talk about that more. But before that, oops, I'm gonna go back one slide. One thing to note is that this study was done, like I said, with 17,000 people in Southern California. These 17,000 people were all registered in a health insurance program. They were primarily middle class, middle to upper class Americans, primarily Caucasian population. So it's possible that this sample, although very large, might not be representative of other populations in America. It's a pretty specific subset population. So in 2009, there was a 6-state study done that replicated the ACEs study they did in California to take a look at how these other states pan out with their ACE rates. And Alaska was part of this study. And what we found here, compared to the other 5 states on the slide, Alaska rated among the highest rates of emotional and verbal abuse, sexual abuse, having an incarcerated family member, having substance abuse in the home, or experiencing a separation or divorce, and we were a close second in exposure to physical abuse and the witnessing of domestic violence in the home. So, and these numbers were quite a bit higher. These are all percentages here. Were a bit higher than the Southern California numbers were to begin with, and then Alaska popped up even higher. All right. Again, these data here were done at the population level. So the Alaskan data that were collected here, they randomly selected people from the state of Alaska and interviewed them. So in theory, these data are representative of Alaska, the population as a whole. However, there's likely subpopulations in Alaska who might be more likely to experience traumatic experiences or adverse experiences based on where they're situated. For example, people who experience homelessness. There's a vast amount of data that suggests between 50 to 75% of people who experience homelessness have experienced at least one traumatic event, and trauma has been directly linked to lifetime homelessness. So in 2017, there was a study done here in Alaska that took a look at rates of adverse childhood experiences at the Brother Francis shelter, so among adults who were experiencing an episode of homelessness. And what we see here is, in this column is the Alaska data in general that I just presented on the previous slide. This column is the Brother Francis shelter data. So folks at the Brother Francis shelter were less likely than the broader Alaskan sample to have experienced 0, 1, 2, or 3 adverse childhood experiences before the age of 18. However, 55% of the Brother Francis shelter sample experienced 4 or more adverse childhood experiences before the age of 18. So perhaps not surprising, but we didn't have these data prior to this. This sample in Alaska, or the subpopulation of Alaskans, experienced significantly higher rates of adverse childhood experiences than Alaskans in general. These data here are broken down. They're the same data broken down by the different forms of adversity on the axis here. And the orange lines represent Brother Francis shelter guests. The blue lines represent Alaskan adult survey in general. And just by scanning that slide, you should be able to see that Brother Francis shelter guests consistently and statistically significantly experienced more adverse experiences across the board than that general Alaskan sample. All right. So in summary, what we know from the large ACEs study that we started with, and then the 6-state study that we looked at, and then the subsample study, is that adverse childhood experiences are not uncommon. They're not uncommon for the general population, and they become more common the more marginalized populations are. We know from these data that adverse childhood experiences are related to a whole bunch of other issues, psychosocial issues, that can lead people to actually have fewer years of life, a shorter life expectancy in the long run. And we're going to talk through some of these other segments of the pyramid in today's training. One thing I want to remind everybody of here is that the data we just reviewed are all population level data, and there's nothing that we just learned or that I presented to you that supports the idea that exposure to a certain form of trauma will lead to any kind of negative consequence. There are a lot of people who have experienced all forms of adversity and go on to live extremely healthy, long lives. But what we do know is that at that population level, certainly exposure to adverse childhood experiences increases risk for a number of health problems that we want to be sensitive to, that we as physicians or psychologists or social service providers want to be sensitive to, want to shape our services around so that we can support people in their recovery. In addition to those adverse childhood experiences that we just went over, we also know that people who experience homelessness experience higher rates of all sorts of forms of trauma compared to the general population. And there's just a whole bunch of different forms of trauma listed on the slide here. It's important to note that just because somebody experiences something that we see on the slide here doesn't mean that they will perceive that experience to be traumatic. There's an element of perception, a psychological component to trauma that's important to note. But these are things that are documented in the research that can lead people to have traumatic reactions. And again, that core element of what makes something traumatic is the sense that somebody is helpless in that moment, overwhelmed by horror, by what's happening, and helpless to do anything with what is happening to them. That's sort of that core component of what trauma is that we'll talk further about. In order to really understand what we're talking about here today and why those first slides were important to go over, and how is it that somebody could be exposed to adversity in their childhood and have that impact them across their lifespan, it's really important to take a step back and think about how human beings develop. So we're going to spend some time talking about development of the human being from the brain up. All right? This is when things will build up into a little bit of some technical language, but that's okay. Remember, you don't need to remember any details today. All right, so human development, let's define it. It involves two things, maturation and socialization. So maturation can be thought of the image on this slide, how somebody changes across their lifespan. Maturation happens kind of similarly across all cultures, across all contexts. We're all born kind of helpless babies, and then most of us crawl. Not everybody crawls, but most of us crawl, and then we start walking and we do this thing, and then slowly we get older and we all end up, in the same place, at least here. Okay, so that's the maturation part of human development. Socialization is the lifelong process of how one becomes a member of their society. So while maturation is something that's kind of a cross-cultural phenomenon that happens largely in the same way everywhere, socialization is really what makes us all incredibly unique from each other. It's why we have people across the globe who are made up of basically the same exact biological constitution who experience the world so incredibly different. Because we interact with the social and cultural environment around us, and it shapes us, it shapes our brains, it shapes who we become in this world. Okay, so that's my definition of human development. It's actually Kajitsi Bazi's definition of human development, but okay. We'll take it a little bit further here. This is Urie Bronfenbrenner's ecological systems theory. So we talked on the last slide real simply, right? Humans are born, we mature across the lifespan, but yet we interact with these systems that make us really unique. So this is a model that helps us be able to break down the systems in which people develop and think about how those systems might influence that individual in the middle of them. So I'm going to walk us through this model, and then we're going to do a brief activity. All right, so in the middle of this system is you, or me, or the individual. You, me, the individual, we are all made up of biology, right? We all have genetics that were passed on to us that kind of set the stage for certain elements of our experience. We all have psychological tendencies, right? Things, the way we think, the way we see the world, etc. We all have our own beliefs and systems of beliefs, things that are contained within us. That's the you, all right? But the you is embedded in a microsystem. Again, you don't need to remember this language, but you are embedded in these other systems. You interact every day, for example, with your workplace. You are all in an element of your microsystem right now, Covenant House. You all work here or somehow interact here, right? Other elements of a microsystem might be one's family, their neighborhood, their peers, a religious affiliation, etc. So any place that you directly interact is part of your microsystem. Who cares? Why does this matter? It matters because the microsystems that individuals interact with can be more or less likely to be supportive of that person. People may be more or less likely to, for example, experience adversity or a traumatic experience. They might be more or less likely to disclose that experience based on their interactions with those systems that are around them. Okay, everybody's with me so far? Okay, so we're going to bump out a little bit further. So most people get it to there, then they're like, what? These other systems, why do they matter? So I'm going to try and sell you here. So the next level of the system is the mesosystem. And the mesosystem is a system that the individual person doesn't interact with at all, okay? In this system, what we're talking about, of course this is conceptual, right? But what we're talking about in this level of the system is how the different components of the microsystem interact with each other. Okay, so an example, we are all here sitting in Covenant House. So we all share an element of a microsystem. So Covenant House is part of the mesosystem as well. But the mesosystem would be more about how Covenant House interacts, for example, with the school system or with my family. Does Covenant House interact with your family, my family? Do they support you, say, if your child is sick, to stay home for the day? Or is it like, oh, I can't stay home because I'm going to get in trouble if I don't go to work? You see how Covenant House interacts with our other elements of our microsystem. Even though you might never interact out there, you are influenced by it, or the youth that you're working with, or your child, or whoever is most helpful to envision as that you in the middle. Okay, so the way our systems interact with each other will influence our well-being. Bumping out further from that is the exosystem. So we're getting even a little bit more vague here, or not vague, but bigger. We're getting bigger here. Out in the exosystem, we have the broad economic systems, the political system, education system, government system, etc. We're talking about here our society, right? The society that we're living in. This could exist in many different societies, but when we think about this, we want to think about the dominant society that we are all embedded in, okay? So of course, our government, for example, sets policies that impact our life, our health, and our well-being. Even if we never directly interact with our government is certainly influencing our daily life experiences. It's also influencing, your organization here, funding to this organization here, whether you can serve the populations you serve, etc. Okay. And broader than that then are the overarching beliefs and values of the society that you're embedded in, right? Of the United States, for example. So I don't know, what are some values of the United States that y'all could throw out? One of the values is individualism, right? I would add rugged individualism, right? So that we are self-focused, but it really roots back into our history. The history of, at least the colonized history of the United States, is very much oriented around this idea of like pulling yourself up by your bootstraps, doing it on your own, etc. So that can be reflected in some of our systems, right? That might impact the organizations, that might impact our families, that might impact our own health, etc. So you're kind of seeing how this stuff matters a little bit? Okay, I'm going to bring it one more step, just for fun here. We're going to bring it out to the broadest system here, and that's the chronosystem, or the element of time, or the dimension of time. And what that simply represents is that this microsystem, this ecological system here, is moving through time. So you are embedded in here, and you were once a baby, and now you're however old you are, and you're going to continue to move through time. So the system will shape and move, and it's dynamic over time. It also represents some of those elements of history that might impact us, right? Like, where do our cultural values come from? Like we were just talking about there. What are your ancestors' histories? Where do you come from? How does that impact and bump up with the system that you're embedded in today? So at each level of this system, it really can help or hinder people's recovery from trauma, the likelihood of exposure to trauma, to adversity, etc. Want an example? I'm going to give you a case example. Okay, so this is not a homeless case example, but I've done a lot of work with refugees in Anchorage. It was my primary specialized population when I got licensed as a psychologist. And I worked with a particular youth at one time who came here from Somalia. And so that was him in the middle, right? This youth was biological, right? He had whatever genetic makeup he had, and his psychology and his belief systems that he brought with him. And then he came to the United States. And in the United States, of course, he had his family system here. He had a school that he attended and peers at his school. He had a religious affiliation. He was a Muslim man or young man, and he had a neighborhood that he lived in, etc. So each of those elements sort of interacted together to influence his life. And then outside of that, his family, who were all newcomers here to the United States, interacted with the school district. And there were some challenges with his family interacting with the school district just based on language ability, how they communicate, how do you get an interpreter on the phone? Does the school provide the funding for them to get an interpreter on the phone to be able to communicate with the family? What happens if information doesn't get back to the family? How does that impact that youth, etc.? So you can see how that system may have influenced this young man. Popping outside of that, then, he was embedded in a system where there was a lot of talk at the time that he resettled here about whether or not refugees were welcome in our communities, right? So that influenced his experience of being embedded in this dominant system. And also, some of those broad policies there impacted his family being able to come to the United States, the rest of his family, who was stuck somewhere else that wasn't safe, right? So his ability to settle and feel safe and secure in this new environment was actually very challenged by these broader systems that were happening in our country because he, had loved ones who couldn't actually make it here. If we go further out from that, the overarching beliefs of the United States at times clashed with some of his beliefs and practices. And then we have the historical context through which he came from. So for me, as a psychologist, I very easily could have stayed here with him and said, here's this individual in front of me who's experiencing challenges, right? And tried to treat him. But he was embedded in levels of a system that really weren't being helpful to him in some ways. And there were some places of the system that I couldn't do anything about. But I could do something about helping facilitate communication between the family and the home so that there was a better understanding of what was happening with the youth and he wasn't getting kicked out of school because of X, Y, or Z, right? So I was able to, I think, be more effective by understanding how this individual was being impacted by the systems around him and be able to intervene in those systems. Now it's your turn. So everybody has in front of them a sheet of paper with Bronfenbrenner's model on it. And I would like for you to spend some time in your mind, pull up a youth that you work with, If you can't come up with anybody, you can think of yourself, do some self-reflection here. It doesn't matter. It's just an exercise of thinking about the systems. And just take a moment to jot down what you know about that youth at that individual level. Micro level, meso level, exo level. You can look here. Jot down some of your thoughts. I'm going to give you like a few minutes, and then we'll pull together in some small groups and just discuss what this was like for you. So everybody clustered together into small groups and debrief the activity with one another. I want you to think about if there was parts of this that was easier for you or harder for you, if anything came up for you, if you figured something out that you didn't think about before, if you find it useless. There's no right or wrong answer. But get together, make sure you all are included in a group and have some debriefing. So 2 comments that I have about this activity. One is that to remember where we reside in the system for the people that we're working with and how we can influence the experience of people that we work with. So obviously, we interact with individuals here. You all interact daily with individuals here. And you have an opportunity in those relationships to, help or hinder people's experiences. You also likely interact with people's families to some degree. You also interact with other systems like the school district, etc. You may have the opportunity to help facilitate communication between different elements of the microsystem. For example, law enforcement in a family, right? Helping to smooth over some of those conversations, help people understand one another, etc. You also have the opportunity to get involved in the broader levels of our system, being aware of policy level issues that are happening in our community. Get involved in boards, go vote, etc. Those are all opportunities that we don't necessarily think of. I don't know if you think of it this way, but we don't always think of those civic activities as part of our professional role, right? Like, can we really impact people's lives by how we involve as civic members of our society? I think you can if you choose to. So it's just helping us to think a little bit about how we can be influential in multiple ways. But really, the reason I did this activity was to help us start thinking about how people develop within these multiple layers of the system and how some of the behavior that we might see people presenting might be as a result of these levels of the system. So I'm going to introduce to you a philosophical concept called functional contextualism. Again, not something you need to remember. Remember the essence of what I'm going to tell you here. So functional contextualism is actually a philosophy of behavior. And the philosophy states that all human behavior is goal-directed. So everything that we do, we're doing it for some reason. And it's functional in our context. Okay? So everything we do for a reason, and we get something out of it, essentially, is the philosophy of functional contextualism. And this is important when we start thinking about how the people that we work with might be behaving in ways that seem really, out of sorts, perhaps, or problematic. But perhaps the way folks are behaving per this philosophy, if it's functional in their context, how do we actually intervene then effectively to help people versus thinking they're doing something, out of spite or whatever? So a good place to start thinking about this functional element of development is with the brain, yeah? Should we think about the brain? Let's do it. All right, so this is a brain theory called the 3-part brain theory. And it is a functional model of brain development. Now I'm going to break it down for us. So the first part of the human brain to develop is what we're going to call here the reptilian brain. So if you reach the back of your head and touch right at the base of your skull, that's where this part of your brain is housed. It contains your brain stem. And it's called the reptilian brain because it's the part of your brain that is shared with all other species that, live, that have life on Earth. And the functions of this reptilian part of our brain, the instinctual part of our brain, are all of the things that we actually don't need to think about. So the functions of that part of our brain are to help us breathe. It regulates our temperature, our heart rate, etc. It's cool that we don't have to think about it, because if we had to sit around thinking all the time about like heartbeat, 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 or whatever, we wouldn't really have probably evolved all these other parts of our brain. We'd still be sitting there telling ourselves to breathe or something, right? So we don't have to think about it. It's the automatic part of our brain, but this is a teaser for level 2 training. You can actually work with that part of the brain and bring some of those automatic functions under conscious control. So you can actually work there, but you don't have to unless you're really intentional with that. So we can go into that more at another time. But that reptilian part of our brain, automatic functioning, it keeps us alive, essentially, right? So moving on from there, the next part of the human brain to develop is what we're going to call the limbic brain, or the emotional brain. It's this part of our brain here, deeply embedded in our brain. So we start here and we start moving up, but it's deep inside the brain. And this emotional part of our brain develops largely in the first 2 years of our life. So from the time we are born to 2, our experiences that we have largely build the neural networks, the brain networks, that we still utilize. Every single one of us in this room still utilize those networks in our interactions, right? So we can think about this part of our brain developing in a use-dependent manner, right? So the neurons in there, your brain cells that fire together in those early years of your life, wire together in a way that becomes what we might term our default network. When we're not really being super conscious and thoughtful about what we're doing, it's where we default. We all got it, right? We all have our moments where we default somewhere that maybe isn't where we would go if we were being really intentional with what we were doing. So our default network there. It also forms, this area of our brain forms what we might call our attachment system. And our attachment system really represents the way that we relate to other people. So if we have experiences in our very early life that help us to see the world as a safe, secure, trusting place where our needs are met. We cry and we are comforted. We're wet and we get dry. We're scared, etc. Our needs are met. That part of our brain will develop into a default that's kind of like, yeah, the world's pretty safe, generally speaking. The world is pretty safe. If, on the other hand, we have early experiences that aren't safe and secure and trusting, perhaps for whatever reason, our basic needs aren't met readily. Perhaps if we cry, we aren't comforted right away. Perhaps love isn't readily available to us. Perhaps even the people who are there to love us aren't able to. Then that default network can develop into a less trusting view of the world, have more difficulty kind of knowing how to read people and knowing if people are safe and comfortable, okay? So that's our default network in a very simplified manner, of course, right? It's far more complex how we develop there. That's the simplified version of it. And this is where I'll remind us too that even though we all have our default network, there's always opportunities to heal and grow and to change the ways that we relate with other people. This is not a deterministic, if this happens to you, then you'll be this way, okay? I'm a therapist. I believe that we can change. Okay, so that's our emotional part of our brain. And then finally, the last part of our brain to develop is the part that we see in all images of brains, the sort of squiggly part on top called the neocortex, or the thinking brain, the rational brain. That's the part of our brains that make us largely human, right? It's a part of our brains that is rational. We can think through things, we can judge things, we can think critically, we can make decisions, good ones, not good ones, but intentional decisions, right? That's the thinking part of our brain, the last to develop. In fact, it continues to develop through till about 25 years of age for men, 22 for women. We're a little ahead of the game. But that part of our brain continues to develop over our lifespan, far longer than these other parts of our brain. Okay, so 3-part brain. I'm going to dig deeper into this, and I'm going to boil it all down to the coffee table conversation here, so don't get lost in the details. But what we're doing now is we're now diving in to that limbic part of the brain, that emotional part of the brain, that use-dependent part of the brain that we talked about. I'm going to introduce a few of my favorite brain structures to you. The first one is the thalamus. You can see it here in the deepest part of your brain. It's kind of shaped like an avocado. And that thalamus can be thought of as the cook of the brain. So everybody right now has an active thalamus as I'm talking to you. As I talk to you, your sensory information is coming at you. So you have me talking to you, the tone of my voice, the crinkling of the plastic, you have visuals outside, you have lights flickering, you might have a phone vibrating, right? There's tons of sensory information at any given moment that's coming at you. And your thalamus, the job of it is to take it all in and kind of stir it up, right? So it's like the cook. It's there with a spatula stirring up all the information coming to you. Then it shoots information out into 2 different directions. One direction is toward another deep limbic system structure, another emotional structure, and that's the amygdala. So the thalamus cooks things up and it shoots it out in 2 directions. One direction's to the amygdala. And the amygdala can be thought of as the smoke detector. And when information hits, the sensory information gets the amygdala, it determines if this information is dangerous or not. And if the amygdala perceives the information as dangerous, it sets off the alarm, which is the stress response system. So your body gets flooded with adrenaline, and you get ready to either fight or flight. That's what that part of your brain does. However, if the amygdala doesn't perceive the information as threatened, it doesn't sound the alarm, so the information can continue along to the medial prefrontal cortex, which is part of your thinking brain, okay? So it comes out of that limbic, emotional part of your brain into like right about here, right? The middle of the front part of your brain. And we can consider that structure the watchtower. So that part of your brain then is able to think about what's there, right? So the alarm doesn't go off, it gets up there, and then you can be like, okay, interesting. What should I do with this information that's coming at me? It's the thinking part, the rational part of your brain. Okay. So over here on the slide is what I just shared with you, the 2 different pathways that the thalamus sends information. So it sends it along what we call the low road, which is the road to the fire detector, and it sends it along the high road, which is your thinking road. The low road moves just a little bit faster than the high road, which makes sense functionally, right? As human beings, if we were to survive all of the difficult things we have survived as a species, we need our fire alarm to go off so we can behave and keep ourselves safe to fight and flight and live, right? We don't need to think. I mean, we do, but first you need to stay alive, then you get to think, right? Okay, so low road goes a little bit quicker. If alarm goes off, stress system goes off, this doesn't come online and you just behave. Low road goes a little bit slower. So essentially, if you're using this low road, you behave first, think later. Okay, there's lots of research that shows this, that when our body is filled with adrenaline, we act. We don't think. We think about it later. We've all experienced that before. You're driving down the road and somebody pulls in front of you and you slam on your brake and then you realize somebody pulled in front of you. You know what I mean? You're like, oh, well, I'm glad that didn't happen. I'm safe. Whew, right? So you behave first, think later. The issue is that's all good. That's totally functional, right? We want to act that way. We want to have that function in place. But when people are exposed chronically to adversity, whether it's early adversity in the form of not having your needs met, et cetera, exposure to domestic violence, some of those other things that we saw, or a very overwhelming traumatic experience, right? Like a car accident or exposure to a natural disaster, something like that. If that system here shortcuts, then that can become the default system that somebody lives in pretty regularly. And that thalamus there, research has shown brains under scans triggered into a traumatic state. And this thalamus goes offline. It doesn't do its job well. It doesn't send information where it's supposed to be sent, right? So your sensory information gets all out of whack, and we see some shortcutting of information. So therefore, if you are stuck in this kind of low road functioning, it's then difficult to perceive whether information is safe or not, because this guy isn't doing his job. He's not cooking things up the right way. So I could be talking to you up here and presenting to you, and maybe I move in a particular way, or I use a tone of voice that threatens you for whatever reason. We don't have to have an explanation for it. That something that's simple, the tone of voice, a lighting, a smell, can trigger somebody into this low road functioning. Okay? So now, this is the fun part. This is when we boil down everything I just told you into a hand. Ready? Okay, so everybody put your hand up. We're going to make the brain. This is the coffee table conversation. All right, so here we have our wrist. The wrist represents that reptilian brain, right? We have our brain stem, the base of our skull, our spinal cord, all the stuff that needs to happen happens here. Fold your thumb in, and that is your emotional brain, or your limbic system, right? So that's where that amygdala and thalamus and all that lives. Then if we fold over the top, that's your cortex, the neocortex, the thinking part of your brain. So now you can really easily, give a brain model. But when that low road is triggered, right, that stress response is triggered, exactly, pop, right? The thinking part of your brain flips. You flip your lid, right? And when you flip your lid, you're not thinking, right? You're behaving. So I'm venturing to guess that you all are familiar with flipped lids around here, right? You may, if the data are correct that we reviewed at the beginning of this, you may work with people who largely walk around like this. And you might not even know that they're like this, okay? And then, what do we do with people when they flip their lid? Oftentimes, we try and engage the part of their brain that's not online. We try and talk rationally to them, talk them down, engaging here. What are you doing? Why are you doing that? You're going to get yourself in trouble, blah, blah, blah. But if this isn't online, who are you talking to? Okay? Another teaser for level 2 training. We're not going to go into that today. But the idea is we want to work on getting people's lid on before we try and rationalize with them. Okay? So, human stress response. This is just a little bit further on what we were talking about there. So this is when the lid is flipped. This part there, the autonomic nervous system, so that part of our nervous system that we don't have to think about, right, has 2 different branches. And we don't have to think about any of these things. One branch is the sympathetic nervous system. We were just talking about that. That's the fight-flight system. So when your lid flips and you run or you fight, you are in this system here, fight or flight. The flip side of that system is actually a lovely system that we don't have to think about either. That is the parasympathetic nervous system, or the rest and digest system. So similar to you not having to think about behaving here, you also don't have to think about like helping your body digest your food, etc., right? Your body does that stuff without thinking about it. But these two things can't be functioning at the same time. So when your parasympathetic nervous system is activated, this branch of your nervous system is suppressed. So it works in harmony. It's what we're supposed to do, right? Those things work in harmony with one another. Fun fact? Want a fun fact? Okay. So deep breathing. How many people here have been told just like take a deep breath and calm down? Okay, right? So there's science behind that. It's not always helpful when your lid is flipped to be told to take a deep breath and calm down. But so what happens when you do take a deep breath, particularly very intentional, specific kinds of breaths, you activate your parasympathetic nervous system. Okay? And when your parasympathetic nervous system is activated, this one can't be activated. So if you're really anxious, really nervous, feeling really angry, and you do some really intentional breathing, then you can activate this side of your nervous system, which really does literally physiologically calm your body down. But you can't be like, that doesn't work. That actually activates this side of it. So there's intentional breathing. Again, level 2 training. I'm really selling that training here today. Okay. Another image here that can perhaps help us understand some of those early data that I showed that demonstrated how early adversity, et cetera, can lead to lifetime illness. So over on this side of the slide are all of the different human organs that are activated when your fight-flight system is activated, when your lid is flipped, when you're filled with adrenaline, et cetera. Things happen to you, right? Like your heart rate increases, your stomach activity is inhibited, your immune system is suppressed, glucose is flooded throughout your body, right? So if you think about it, again, this is great if you need to like fight something in a moment. You need all of that energy. You don't need to be digesting food at that moment. But if you are living most of your days in that state, and your body is continually flooded with glucose that you're not utilizing because there's actually nothing to fight, right? You're not actually utilizing it, you're just flooded with it. If your immune system is suppressed all of the time, what does that make you susceptible to? Lots of things, right? So this should help you understand where that might come from. So trauma disorders can be best understood as disorders of the sympathetic nervous system. We're not just talking about trauma disorders today. Disorder doesn't even really matter. We're talking about how adversity can just sensitize the body to many of the responses we're talking about. And the trauma disorders that we do have, the ones that I'm able to diagnose people with to be able to reimburse insurance and treat people, are actually really limiting. The main disorder we have is post-traumatic stress disorder, which really doesn't capture some of the more complex experiences related to early and relational trauma experiences. But what's similar between disorders and between these early adversities is that sympathetic nervous system is really implicated in everything that we're seeing. And that's the take-home message. That's what I want you all to remember today. You can forget all the details that I told you. I want you to remember this guy and that you're working with people that are doing this a lot, and start thinking about how you might actually want to interface with somebody if they're like this, so you can help them get like this so their bodies can digest their food and not be flooded with sugar and disease-promoting hormones, etc. Any questions or comments based on what I've shared? Yeah. So de-escalation strategies are very helpful. I don't know if you've okay. So I'll give you a couple simple things. When somebody is like this, it can be helpful to just listen, right? So oftentimes we have a really hard time. Again, I'm not saying they're violent and breaking things, that's a different story. But if somebody's yelling and really angry, oftentimes our inclination is to make them stop, right? And to talk them out of it. And we tend to then not listen to people. So being able to step back and listen to somebody and even validate what they're saying, not validate their behavior, right? You don't say, yeah, I totally understand. I'd be smashing a window right now too if I was you. Like, it's not the behavior, but to be able to listen to somebody and say, I can see how that would make you mad. That would make I could be mad about something like that too. So just listening is probably one of the greatest things that you can do. And then there's other ways you can intervene to help people, like slow their breathing. It's good to encourage things like going for a walk, using one's body versus using the brain, essentially. But I would say that there's some real simple de-escalation strategies that can be helpful, and the biggest parts of it is just listening and validating where people are at, not trying to tell them that what they're feeling is wrong. Let's talk about some behavioral manifestations of trauma. So these are some of the things that you probably see in your work here, and we're going to go through each of these individually. But these are the main categories are in the human attachment system, the body, the physical body, mood, dissociation, which I'll define in a moment for you, difficulties with behavioral control, cognition or thinking, how we think about things, and self-concept. So I'll go through each of these independently. So if you recall, when we were talking about the brain and we talked about the development of this emotional brain, I said that's really the center of your attachment system, right? So all of us, every single one of us has a way of relating with others that dates back to that stage of our life, right? Because that's when those neural networks are building, and how we were interacted with has shaped the way that we interact with the world today as adults. And there are different theories of attachment systems. I'm not going to go into those details because they really don't matter today. What does matter is that when there is very significant adversity or trauma in those early years of life, we can see the manifestations of trauma in relationship, right? And in the way that people are relating with us. So let's walk through a little bit of what this can look like. It's possible that somebody with early traumatic experiences might develop a distrust in the world. In fact, it could be a distrust even in themselves and others and the world, not really having a good sense on where they stand and how they behave in relation to others, how people relate to them, and how the world relates. So this can be a challenge in developing relationships. So a manifestation of attachment problems can be relationship challenges. People who've experienced this form of early adversity can have a lot of difficulty setting boundaries, understanding boundaries, literally physical boundaries, where I begin and you end, and where you begin and I end, what's okay, what's not okay, emotional boundaries, what's your emotion, what's my emotion, what's, being able to have those sorts of boundaries is something that is inherent in attachment systems and teachable. So this is a place where you can actually intervene very well with people, but it can be really challenging for folks. Within relationships, of course, that distrust can manifest for people, and some suspiciousness if that early system is not trusting. You might see folks who are very isolative, not knowing how to or wanting to interact with other people, and we know that social isolation is a predictor of depression. It's a risk factor of suicidality. So social isolation can be a real problem. You can see folks who have challenges relating to and empathizing with other people, right? So what I mentioned earlier was empathy is the idea that we can kind of see the world from somebody else's perspective, right? And to be able to do that, you kind of have to be able to step out of your shoes a little bit, or to be able to project a little bit of your emotional experience to understand somebody else's. Like, I've been sad, so if you're sad with me, even though I might not be experiencing what you're experiencing, I get sadness, so I can come alongside you because I get that, right? That's empathy. But folks who have some of these early disruptions, or maybe not even serious early disruptions, right? Just learning, right? All of us have gone through different learning experiences. Like, many men are told, don't feel, don't cry, that's not okay. So we all are patterned in different ways that can make this really challenging. Okay, so those are some of the manifestations of attachment that can show up in your direct interactions with people. And yeah, we'll talk about what to do with that a little bit today, a lot next week. Physical body manifestations. Often you'll hear folks talking about hypersensitivity to physical contact. So this can literally be hypersensitivity to being touched. Also, hypersensitivity to somebody coming close to them, or brushing up on them, or anything like that. Insensitivity to pain. This is something that there's been some really interesting research done actually with Vietnam veterans on literal changes in the body and sensitivity to pain that's tied into that whole sympathetic nervous system malfunction. But you can see that manifest in folks. Unexplained physical problems like chronic pain, and increased medical problems, things like asthma, skin problems, autoimmune disorders. Autoimmune disorders are often disorders that we don't have a really good understanding of the cause of these disorders, but we do know many people, not all people, but many people who have autoimmune disorders have histories of trauma. There could be some relationship there, even if it's just the relationship is the trauma experience makes it more difficult for folks. Mood dysregulation. So folks might have difficulty identifying their feelings or identifying others' feelings or the desires of other people. One of the things I didn't mention here, which might be out of place, but I'm going to mention it because I'm thinking of it now. When that lid is flipped, that part, I said there was some research done that took a look at the brain, like the flipped lid brain essentially, what's happening there. Something that also happens, in addition to the cook kind of not doing its job, is that the language center of the brain is also offline. So the part of our brain that helps us like put together the pieces of what has happened, that's largely language. I'm able to say today that like, I got up this morning, I had breakfast, I went to work, I worked on a PowerPoint, I came over here. Like, my story helps me make sense of my day. But when somebody experiences a traumatic experience, that language center can be offline. So again, it can be difficult to engage somebody with language when their language isn't online, but it can also be really hard for people to kind of put the pieces of their story together, which can lead to a lot of distress and difficulty being able to identify, like, how do you feel right now? Sometimes people literally don't have the language to describe what they're feeling. So when we work with folks in trauma therapy, often we're working with like art and sensory kinds of factors to get around that language piece nowadays. Mood swings are common. So if we think of this whole thing, right, if somebody's lid is flipping on and off and on and off and on and off, you can imagine their mood can be up and down and up and down and up and down. Actually, there is quite a bit of research that suggests people with complex trauma histories are diagnosed at higher rates, misdiagnosed at higher rates for having bipolar disorder, right? Manic and depressive, when it's really them having difficulty regulating their emotions, which there's big implications for, because the way you treat bipolar disorder is quite different than trauma. Angry outbursts, behavioral outbursts, aggression toward oneself or others, self-harm is often an attempt to regulate emotion, ties into the other things that we were talking about with pain and sensitivity, but often people who self-harm will say they're self-harming so that either they can like visually manifest the pain that other people don't understand, right? If I break my arm, you all are gonna know that looks like it hurts, right? But if I'm carrying around emotional scars that none of you can see, it can be very, and I don't have language to express it or explain it, or people can't handle my story, then a function of self-harm can be to show you my pain. Likewise, self-harm can also be a way for somebody to feel something. So one of the most challenging symptoms of trauma for people that I've heard is an overwhelming sense of nothingness and numbness. So not feeling all over the place, but feeling nothing, empty, dead inside. So self-harm can be a way of trying to feel anything. Okay? Suicidality is similar to those functions. Oh, and of course, substance misuse is very common among folks who have trauma histories. So trying to utilize something to regulate emotions, to feel something, etc. Dissociation we haven't talked about in here, but I think it's a little bit of a complex topic, but I think it's really important to touch on because you probably see it whether you know it or not. But dissociation is a common symptom of trauma, and what it can be described as is feeling really disconnected from other people or detached, feeling like somebody's kind of in a dream world, not really in their body. Sometimes people might describe looking at themselves in the mirror and it just doesn't like, it's not even them. It's not them in the mirror looking back at them. Those are some of the more common experiences you'll hear, and dissociation can go to an extreme where people actually have amnesia, gaps in memory, significant gaps in memory, etc. This image, don't look at any of the words on it. It's too wordy. We're not looking at words, just look at the colors. We're gonna walk through the colors. What we have here is essentially our hand again, right? Down at the bottom here in the green would be a brain that is fully functioning, right? Lid on. It's engaging socially, compassionate, mindful, able to engage with the world, etc. When we flip our lid, we come up here. This is when our sympathetic nervous system is activated, and we're now in the red. And in the red, we're ready to fight or we're ready to flight. And there's some symptoms here of what fight and flight might look like, right? Like rage, anger, irritation, frustration, panic, anger, fear, etc. But what we haven't talked about is what happens when somebody becomes so overwhelmed by an experience that they pop out of the fight-flight stage. And that's what dissociation is. I'm not going to go into details of the biology of it, but there is a biology to it. It's called the dorsal vagal response, where there's literally just a shutting down of one's brain. Other animal species do it too. You can see this on those safari things where, anyways, you can see it other places as well. But so the freeze stance, the fight-flight thing is you're ready to go. Freeze is essentially you completely shut down. So when you see this in more everyday circumstances where somebody has a trauma disorder, they might not be freezing it to a state that you know that that's happening to them, but you might hear them talking about it, feeling numb, feeling underwater, depressed, not being able to come up with language, mass amounts of shame, shutting down, feeling hopeless, etc. So you work with a person in this state quite differently than you would in this state, and guess when you get to learn about that? Next week, exactly. Okay, so you probably are familiar with many of these things, behavioral control kinds of issues, aggression, poor impulse control, fast heart rate, sleep disturbances, nightmares. These are all very common manifestations of trauma. Eating disorders as well. If you think about eating disorders, one thing, when somebody feels out of control of all elements of their life, there is something they can control, and that is eating. So eating can be a functional manifestation, again, of trauma. We can see difficulties with attention and planning, anticipating events. And I guess my point in going through all of these symptoms here is to help you remember and think about that some of these elements that we're looking at can be really frustrating. If there are teachers in the room, are you an educator? You are, aren't you?
Yeah, I work for education.
Yeah, okay. So it can be super frustrating when you're working with people who aren't focusing, aren't completing tasks, aren't attending in a classroom, et cetera. And sometimes the ways we intervene with folks, like, and you see this in the school district all the time, we punish kids for not attending, right? When actually it can be a manifestation of something at the level of their brain. So we're punishing people for their trauma, which can be traumatizing, and that would not be a trauma-informed approach. So when we get into thinking about trauma-informed consequences, it's about keeping in mind that these are manifestations of a brain-based issue, not manifestations of like people being bad, right? Okay. And finally, self-concept. Sometimes folks who have early adversity can have difficulty with just understanding who they are in the world in relation to others. Self-esteem kinds of issues, distorted or disturbed body image issues. And these should be on two different lines. Shame and guilt is very common experiences for folks. Back to trauma-informed care. We started here today. And I want to remind us now that the premise of trauma-informed care, the reason we want to understand what trauma is, how it manifests, how it impacts people, is because recovery is possible, and we are all positioned in places to either help people or hinder people in their recovery. And not just the people we work with, but with our colleagues, with our friends, with our family members, our community members, and ourselves, okay? We all can recover. Healing happens in our relationships. Psychotherapy likes to boast all our bells and whistles that we do in therapy. I went to school for a really long time to be able to do therapy. But I learned something really important along the way, that nearly 80% of therapeutic outcome, right? So how likely somebody is to get better, nearly 80% of that can be tied back to the relationship you were able to develop with your client, okay? So you don't need a PhD to do that. Many PhDs can't do that, right? So we all have the opportunity to develop healthy, nurturing relationships in our lives across many different things that we do, but particularly in this context. And if you can remember that how important that relationship is, how much healing happens there, if you can model to somebody what a safe, secure, trusting, reliable relationship looks like and feels like, you're doing a huge job just in doing that. Okay. And finally, in terms of recovering from trauma, safety and stabilization is the first step of the process. So when I do trauma therapy, the first step of what I'm doing with people is helping make sure that they're safe in their environments, that they have safety within themselves, that they can keep themselves safe and not hurt themselves, not hurt other people, and learn to stabilize, right? Make sure they have a home, make sure they have food on their table, help them develop a sleep pattern so that they're caring for their bodies and eating regularly. So essentially, this element here, this bullet point, is what you all do. This is your job, is safety and stabilization here at Covenant House. You build relationships and you help with safety and stabilization. So I think you're well positioned for this work. Here's this busy slide again, but all this slide is here to do is to remind us that in all of our interactions, we are endeavoring and hoping to help people remain down here. Because when we're in the green, us and them, when we're all in the green, we're able to nurture those healthy relationships. We're able to get creative and come up with solutions and make plans for our future. When we pop up here, we're less able to do that. When we pop up here, we're less able to do that. So our really trauma-informed care, when we talk about building a safe and secure environment for trauma-informed care, we're talking about building a place where people can spend as much time as possible down here, right? And when somebody does pop up here, that we intervene and work with them in a way that's effective and not harmful. Okay. Anybody familiar with Brené Brown? Yeah, I love Brené Brown. Okay, I've been on a Brené Brown binge this year. So this is her work. But I found this, it's a BRAVING acronym, BRAVING. I found it incredibly useful to just the beginning thinking of how you develop and nurture a trusting relationship. So we often talk about, how important it is to develop a relationship, how important it is to have trust in a relationship. But like, a lot of us don't know what that means or what that looks like, or how do we manifest this in our daily life. So I wanted to share this with you just as, a little nugget that you can take with you today. So the first element of building safe and trusting relationships is to set boundaries. And boundaries can be simply defined as what's okay and what's not okay, right? So in our relationships, like, you know what's okay for me and not okay. I know what's okay or not okay for you. And if I don't know, I'm going to ask you. I'm not going to assume anything, and vice versa. If you're not sure if something's okay for me, you're going to ask me, right? So it's that simple, the idea of setting boundaries. This can be thought of at the individual level between you and your client, or with your consumer, or this can be thought of at an organizational level, right? What's okay and not okay at Covenant House? And if you don't know, do you know how to ask? Do you know who to go to, et cetera? Reliability. So be reliable. Don't overcommit yourself. Don't say that you can do things that you really can't do. And don't, know your competencies, et cetera, as an employee here. And likewise in your relationships with the people that you're working with. Don't overpromise things to clients that you can't follow through on. Be realistic, be reliable. Accountability, if you make a mistake, own it, right? A large part of what you do here is model to youth how to work through things, right? So if we make mistakes, if you flip your lid, for example, and say something to a youth that later when your lid comes back on, you're like, oh, I wish I wouldn't have said that. Go talk to that youth and own it, right? Be accountable for what you did, because it models that you are as imperfect as anybody else, but just because you're imperfect doesn't make you a bad person. Hold yourself accountable. Vault stands for respecting the vault, and the vault would be what we would call confidentiality, right? So in your relationships here, help the youth that you work with understand what is confidential, what is not confidential when you're talking to them. That builds safety. You never want to end up in a situation where a youth has shared something with you that you can't keep confidential, right? There's a few of those things. There's limits to our confidentiality that we can hold. But there's some things, like if a youth is sharing with you some private experience that's not outside of the limits of confidentiality, that you keep private, right? That's what builds a safe and trusting relationship between you and that person. Make sure that's clear. Don't talk about youth in the hallways, right? Don't reprimand somebody in front of other people. Respect people's privacy. Respect the vault. Integrity, do what's right, not what feels easy in the moment, right? Sometimes we can have slips in our integrity when we're overwhelmed, but remember, doing the right thing's not always doing the easy thing. Being non-judgmental in the way that you are working. If, for example, if you need something to be well, if you need a day off to take care of yourself, find a way to take your day off. You all have leave here. Don't judge yourself for needing to take some space. If you need a 5-minute break because you are flipping your lid, ask somebody. Say, hey, I need to go take a walk for a minute. Can you cover me? Likewise, that's modeling to others, but also be non-judgmental of your colleagues and of the folks that you work with. And finally, generosity. This relates to extending your most generous interpretations of others' behaviors at all times, assuming that we are all, for the most part, doing the best that we can with what we have, right? Sometimes what we have isn't working, so it's not about just letting people get away with everything. hold people accountable, but assume that you're doing the best that you can with what you have and start from that place in your interactions with people. It's a better place to start a nurturing, trusting relationship than assuming that what somebody has said was intended to, A, B, C, D, E, F, G. Okay? So that is the Brene Brown's Braving acronym. Take care of yourselves. I think, hopefully, this was woven throughout what we talked about today, that a trauma-informed approach to care is really an approach to care that isn't about us and them. It's about all of us. It's about building environments that are nurturing and safe for all of us to work in. Working through that Braving framework helps keep you safe, helps keep other people safe. Take ownership for your own health and your own well-being, and ask your organization to do the same, right? Okay. That's all I have for you. There's some resources here. One I would like to draw your attention to is the Alaska Resilience Initiative. The website there, www.akresilience.org, has a tab for resources that has just a lot of really awesome resource information on there that you might, about ACEs, but not just about ACEs, also about the resilience components of this work, that we are able to recover, we are able to work with folks are resilient, et cetera. So you can find lots of useful information there. Center for Disease Control and Prevention has all of the ACEs research that's been conducted posted up there, and that's about it.